the AAP view is this, and then we're not, and he's just going to scold me or tell me that I'm going to kill my child. And there is a large gray area in the middle of understanding risk stratification, how to talk about it in a more nuanced way.
I'm excited to have Dr. Michael Milobsky, pediatrician for over 27 years, father of 7, grandfather of 5, who's had a long career not only in pediatric emergency and hospital medicine, but also private practice. He has been in everywhere you can be a pediatrician. And we're chatting about safe sleep, meeting real life, discussing our take on co-sleeping, risks, and honest conversations around baby sleep.
We tried because I was also like very dogmatic, and my wife sort of was, okay. And it broke down really fast, really fast. At 2 a.m., I made this decision with me, chronically sleep deprived, and my wife, juggling 3 kids under 4 and newborn after newborn after newborn. Honestly, it didn't last long, and we entered survival mode for a very long time.
Thank you so much for joining me. I'm so excited to have you on the show.
I'm excited to be here as a longtime admirer of your work. Thank you.
Same. When did you start your social platform, by the way, and tell everyone your handle?
Oh, so Instagram is at Dr. Michael Milobsky. TikTok is Dr. Mike M, but that's mostly for street cred.
Yeah, I love it. For the youth, for the Gen Zers. Yeah, I love it.
Square. And YouTube is Dr. Michael Milobsky. And I started social media 4 or 5 years ago, mostly because, I transitioned from being, employed as a pediatric emergency hospital doctor to owning a practice. And it was just one of those things where, hey, if you own a practice, probably a good idea if you own a business to start being on social media. And it's just something that's evolved over the last really year or two to be a much more central part of what I do, because I'm reaching way more people, and it's such a great way to be more effective and to be able to help more people on scale. So that's where I've been spending a lot more time.
I know it's a lot of work to do social, as you can imagine. I'm in that same boat with you. And I always appreciate, we were chatting about this before we started recording, the perspectives, right? Like for me as a doctor who's been practicing for 11 years, I have 2 small children, to be able to learn from you, who is a father of, 7, grandfather of 5, who's been in this career longer. But more importantly, why I was just so excited to have you is I do feel like sometimes we can be very polarizing in the guidance that we give. And I saw a video you did about bed sharing. And I said, oh my gosh, I want to talk to you, because I feel like we've gotten so much in this sort of dichotomy of like, you either do this or don't do this, that bed sharing, all of it is bad. And my recent revelation to understanding more about bed sharing came over the last 5 to 6 years, I would say. I was one of those doctors that came out of residency very much like, you must do safe sleep, which means independent sleep space, back to sleep, bed sharing is risky. And as I started having friends, family, my patients tell me that, listen, I don't want to do it, or, this is what's working, I opened my mind a little bit more, and I was like, I want to talk to a fellow doc like yourself about where we're missing the mark on safe sleep education. And so that first question I have for you is, we know that the American Academy of Pediatrics recommends safe sleep, but there's very little on co-sleeping risk reduction, when co-sleeping is very common around the world. And I'm going to talk more about this bed sharing as the terminology, so people understand that we're sharing a bed. And that is surprising to me, right? Because I was talking to a pediatrician in India, and he's like, a lot of us bed share, and that's what it is. And I'm like, then what are we doing here? So where do you see the biggest gap between the AAP recommendations and real life? And just explain to us what we can do with that information to actually meet families where they are.
Yeah. So I like you, was coming out of training. I actually had 3 children between the end of medical school and the end of my residency and fellowship. And so I was trained and, socialized basically into that AAP sort of very hard view. And that's where it changed for me, because I saw, when you are in this place as a parent, it's sometimes not possible to function. And you are given this very, very hard view of risk, and where I think the conversation and the part in the AAP version, and combined with the fact that, with the knowledge that this is done around the world,
Yeah.
Where are we missing the mark in the nuanced conversation about the risk stratification here? Because it is clearly very different than just the single hard view that's presented in the AAP version. And when we were in this really hard phase of 3 kids under the age of 4, which I don't recommend, but we were
It
there.
happened.
Just,
It happened, and they're wonderful children and now adults. Yeah.
that we and as someone who experiences this talking to families all the time, hey, this is what I at 2 a.m. I made this decision, and then afraid to talk about it or don't want to talk about it because they assume that, well, hey, he's just the AAP view is this, and then we're not, and he's just going to scold me or tell me that I'm going to kill my child. And there is a large gray area in the middle of understanding risk stratification, how to talk about it in a more nuanced way.
And I think you had mentioned we were talking about where the data is missing the mark. And so when we talk about that, what I've seen, and I would love to hear your opinion, the strongest data we have shows that bed sharing is much more dangerous when certain risks are present, right? Like smoking, alcohol use, sedating medications, couches, soft bedding, prematurity, low birth weight, very young infants. However, the research is less clear in where the exact risk of planned lower risk bed sharing, right? We don't have the best data on low risk bed sharing and what are the outcomes with that. And so, lower risk does not mean no risk. However, I think it's important to understand that the data that's always often presented, and I spoke about this on another podcast, doesn't account for if we can reduce that risk. And I don't
Right.
know if you agree
All
with that.
kind of mashed together. And
Yeah.
that's where they came up with this very hard all or nothing approach. And
Yeah.
and the truth of the matter is, every place where there's been some attempt to stratify this, as you pointed out, a full-term baby who's being breastfed, there's no tobacco or exposure pre or postnatally, and a healthy mom who isn't sedated or medicated and who is taking steps around the sleep environment as far as the surface and the surrounding, bedding, pillows. When you take those away, there is a significant change in what the risk really looks like, although it's not been explored specifically and large enough. But it is clearly different. Those are not the same things that they're talking about when it comes to risk,
Yeah.
and the risk really seems to be extremely low. And like you said, nothing is zero risk, but neither is putting your kid in the car to go to the store, and neither is
Right.
giving your
Right.
kid penicillin. Nothing is zero risk. It's all about risk benefit. And I can tell you, as a parent who's been there, and you've been there, and so many of my moms who come to us, they they meet all these criteria. They're exhausted. They need to get some measure of sleep. They pull their 2-month-old who's full term and healthy and is fully breastfed, nurse them, and everyone falls asleep. And everyone's usually fine because they're taking the right steps, and they're reducing all of those issues. And they don't want to talk about it because they're afraid of the response, and they're afraid that they're doing it wrong. And then there's a lot of guilt and shame, but I'm still going to do it anyway. And that's what we need to correct.
Yeah, and we will get into, again, for everyone to listen, because it's important for us as two pediatricians who are talking about this to discuss like our approach in terms of reducing risk as much as possible in a very clear way. But I want to get into more of like why this conversation is important. And you brought it up at the beginning that so many parents aren't truthful when it comes to where their child is sleeping due to the fear of judgment, right? Due to that sort of hard line. And I've heard it, and I've been there. I've been that person, right? And I'm taking ownership of that, and I've changed my ways because I'm like, that's not serving anybody. So how can we as pediatricians, knowing what you just mentioned, right, that there's a lot of nuance, that the AAP takes a hard line in order to make sure that they're creating a broad recommendation and then leaving it to the clinicians, hopefully, to have these conversations? How can we open up the conversations around sleep choice with safety and no judgment in mind, so that we protect babies, keep them safe, but also support families if they decide that co-sleeping is what's for them?
Yeah. I mean, I think first off is leading with empathy,
Mhm.
and leading with um, the nuance that, you know, I know as a parent, I've done it, and I know that so many parents struggle with these middle of the night decisions about if you're nursing, and where your baby's sleeping. So I would love to know what you guys are doing, so we can just talk about the best ways to approach it. And if leading with that instead of how dare you not follow guidelines and da da da. And once again, I think that comes from experience. I think that you have to be a parent on some level to be able to be in that place with them. People ask me, do you have to be a parent to be a good pediatrician? No, you don't.
Mhm.
You have to, but do you need running shoes to run? No, but it certainly helps. So
Yes.
it's one of those situations where I think meeting parents where they are, but accessing your own experience to understand where that place and what that's like in those months and months of 2 a.m. decisions of in total exhaustion and just needing a solution is the place to be and the place to open those conversations in an empathetic, nuanced way.
Yeah. And I would love to add in a little personal experience. So,
Yeah.
with your own kids, right? I know it's your youngest, I believe, is 16.
My seventh child is 16 years old.
Yeah. Okay. How old's the oldest?
She sleeps in her own bed now, thank God. My oldest
Yeah.
is 30 and has four
Um,
children.
oh my gosh. So there we go, right? We have a huge range. As at the time of this recording, I have a 6-year-old and a 3-year-old at the time of this recording.
Yes.
With your own kids, right? You talked about how you were in residency and training when you had a few of your children. And then outside of that, how did you approach sleep with your own children? Like, to be transparent, like, did you follow the sort of, back to sleep? Was there bed sharing happening? And
I
I'm also going to offer my perspective personally, but how that, I just would like to be, I'm just very curious about that.
Look, we tried because I was also like very dogmatic, and my
Yeah.
wife sort of was, okay, and it broke down
Yeah.
really fast, with me, chronically sleep deprived, and on my wife, juggling 3 kids under 4 and newborn after newborn after newborn. Honestly, it didn't last long, and we entered survival mode for a very long time, and that often meant the baby was just there because nursing happened, and then everyone fell asleep and nursing happened again, and then we just because we don't want to wake up the toddlers.
Yeah.
So that's where we tried, but it didn't last long. We were survival mode took over, and I know so many of us and so many of my families. That's where you are because all of us
Yeah.
at 2 in the morning at 6 weeks in.
I relate to this, and I love hearing your perspective because I have 2 children, and again, we talk about the circumstances that may make you where you are, right? So, in my circumstances, I had 2 children, one of which was formula fed. The first one, I had a very traumatic delivery. Breastfeeding was my plan. It didn't happen. I'm very happy with how things turned out. My second, I exclusively pumped, and I just know how I am as a sleeper, that I know that if someone's in the bed like a baby, I didn't feel comfortable with the baby being in the bed. Like, for me, and that's only for me. It doesn't mean another person doing it. Like, how could you? And so, and my husband as well. He's like, I'm actually afraid of rolling over on my baby, and I'm like, okay, sweetie, like. Let's do independent sleep space. My son took to an independent sleep space very well, like the first child. My daughter was like a stage 5 clinger. I love that. I love that about her. She's a cuddle bug. She's
Yeah,
such a cuddle bug. And so to transfer her to an independent sleep space took a lot more work. And that work can be very exhausting, as you know, right? That takes time to teach a newborn how to be in an independent sleep space, because to the point of people who co-sleep, it is comforting to be near someone as a baby. Like, I'm never going to deny that like it's cozy, it's warm. Like, of course, that's why it happens a lot of the times, right? It's
babies are
not
kind of
to
wired that way.
Yeah,
Yeah,
exactly. I don't look at it as the easy way out. I look at it as like, that makes sense. No wonder the baby doesn't want to transfer, because they're cuddle bugs. And I describe something called a cuddle quota. Every baby has a different cuddle quota because of their temperament, right? My
correct.
son did not have a high cuddle quota, and my daughter is a very high cuddle quota. Interestingly enough, my husband has a very high cuddle quota. I do not have a very high cuddle quota. It's very interesting.
It's like
Like,
the story in my home.
yeah,
Yeah.
and so then I say that because the approach had to be different in getting them to the independent sleep space, but maybe, just maybe, it's why a lot of families go to co-sleeping for that baby that they're trying to get them into that independent sleep space. Like you said, they're breastfeeding or maybe even formula feeding, but if they're breastfeeding, I also know, because I nursed and pumped for my daughter, there's a smell and there's an extra comfort that happens with the breastfeeding journey, right? Like, even though my daughter was in an independent sleep space and we got her into an independent sleep space, the moment I walked into the room, because we were room sharing, she would wake up because I swear to God, she probably smelled my boobs. Like, and and I bring that up for all of our breastfeeding moms who are doing the bed sharing, that I get that. Like, yes, we were able to do it. It took a lot of work, but I also had the capability because I had help. I had someone to, like, I had a night nurse to help with the transfers. But I don't know what would have happened had I not had that help, that we would have probably been in the same bed. And I think about all my friends who are doctors, all my friends who know the risk, but still did it because we are thinking and going to talk about this reduced risk bed sharing, which I think is not often talked about.
Not enough, not enough. And it's not brought into the conversation to know that there's lots of ways and factors that have to do with changing the bed sharing conversation.
Yeah. And a lot of the reason why I wanted to have this is that I've been on social for about 6 years, let's say 7 years now. And I'm curious what you think because you've been on for a little less than me. Do you
Yeah.
feel like sleep guidance is actually as divided as it looks like online? Or do you feel like social media extremes are amplifying that? Like, I'm just curious, like, from what you're seeing on social, or maybe you haven't been down the rabbit holes of what people are saying about sleep stuff.
I have been.
How does that yeah, how does that compare? Maybe you don't know, and I can kind of speak to that too, just to have a healthy conversation about what's actually happening in offices
Sure.
versus what people are saying online.
So the social media space is just an amplifier. And so it can take something that may be part of the conversation, but is nothing more than a part, but make it seem so big because controversy and conflict drive views, which is and that's what drives social media things. People want attention, that drives attention. Um, in the office, for sure, it's not that as far as how often I have the conversations. Once or twice a week, a few
Yeah.
times a month, certainly. I have 30 newborns a month in my office, and so my office is way overrepresented with 2 month olds, 4 month olds, 6 month olds,
I
nine
love it. I
year
love
olds.
it. I know. I love starting their journey with
Yeah,
them, right?
exactly. So
Yeah.
there's a lot, and there's for sure some families just don't tell me. That's
Yeah.
absolutely true. When I bring it up, some families admit, I don't. I've been afraid to talk about it. So I don't think it's as big as you would think because of how it's overrepresented on social media because it drives a lot of clicks and views, but it's
Yeah.
definitely consistent and persistent. And um, I I do talk about it sleep incessantly, and this has been part of the conversation more and more as people are understanding that risk and assessing risk is a nuanced thing, and it's different than the way it's been presented in the standard AAP driven version.
Yeah. Yeah. And again, I'm happy that we're going to chat about that. And we already kind of talked about some of the where that research kind of is is at fault, in my opinion, when we talked about like how it doesn't look at reduced risk bed sharing as much as it could. And maybe other countries can do that for us, maybe, or who's going to do it? I have no idea. Just to kind of show, like, hey, if we take the steps, that it can reduce risk. And I often also my experience as I've gone through being a pediatrician has also come from the stories I hear, the families I hear of the
Mhm.
deaths that happen due to SIDS, right? And a lot of it is, I mean, I'm going to be quite honest, is unsafe sleep practices, which includes falling asleep in a rocker, falling asleep on a couch. And again, this is no judgment to the parents. But what I fear is that did they just not get that education, and that's why it happened.
Exactly,
That's
exactly.
why,
Or they were just told, well, we can't do this
yes,
because so they go to the in my practice, the most recent one was a recliner. It was awful.
yeah, I know, and
Recliner, couch, those are, I mean, by many orders of magnitude, way more dangerous. But they don't get that's not as clear when the entire message is around um, bed sharing is off limits. So
right,
exhausted parents are stumbling into their living room to try and soothe their baby, and
and then they fall asleep.
then
Yeah. Yeah, and I mean, we'll get into what we're going to get into is what are your kind of strategies on like risk reduction and what are hard no's, which we'll get into, which I think is going to be super helpful. And then before we get into that, this experience on social media, I am very pro sleep training in that if a family wants to do it, I love it. But
okay.
when someone is pro sleep training, it people automatically think that they're anti bed sharing, right?
You're
Like that
also, or you might be a monster with
that
the
I'm a monster.
conversation.
So, and listen, I there's a few things. Recently, I did get attacked, because I did share our sleep training journey that is very different than what the recommendations may be. Going back to the AAP guidance, we did sleep train our son much earlier than the AAP recommendation, and there's much nuance to why. Like I don't need to explain it to people who don't know me, but there's much nuance. And my son is a beautiful attached child, all that stuff. But of course, the and I don't want to use the term anti, but it is the people who are against sleep training, let's just use that term, came out and were like not really happy. And I said, I'm like, the reality is like, I can't explain myself to you because you don't know the nuanced conversations that I'm having about that. This is not recommended for all babies, nor do I recommend certain methods for all babies, right? And I think social can kind of create this sort of, it's us versus them. Your pediatrician doesn't know sleep. They're not an expert in sleep, but I am. And over the last 6-7 years of being online, what I'm defending is not co-sleeping. What I'm defending is different methods of approaching sleep. Is that we are looking at the family unit. We are looking at how the lack of sleep or sleep is affecting the entire family. And then we're making decisions with discussions. And that's what's actually happening in my office, right? That it's not, you're going to do this because I said so. It's, hey, how is sleep going for you? Do you have any questions about sleep? So my question to you is, what is that first question you ask the family to not be judgmental? Like when you're meeting a new family, rather than saying like, are you bed sharing, or, are you, independent sleep? What is that first question that you feel really makes that biggest impact to drop the judgment? So maybe they'll open up to you.
I try to be as open-ended as possible and just say, how is sleep going in your home?
Yes, that's what I do. Yeah.
And that gives a lot of space to, well, it's going great and here's why, or it's a disaster. And I can say, well, let's talk about what parts of that. And
Yeah.
then and to your point with your personal journey, and that you kind of referenced it earlier, deeply enmeshed in that was you also knew the temperament of your child, and you
Exactly.
have two different children. Each kid is a Rubik's cube to solve. As Russell Barkley, my favorite, psychology person, is fond of saying, your child is born with over 400 personality traits that unfold as they age. You have nothing to
Yeah.
do with you. It is just who they are. And this is, I remember hearing this in residency, but having no idea what they were talking about until I had a kid. And even when I had my first kid, it was really, really hard to articulate and tune into what those things were. It got a lot easier as I had, we were parents further, then much quicker to go, I know what kind of kid I have. I have a kid who's transitions easy, is laid back, doesn't get worked
Yeah.
up over stuff, but it's just who they are. And then the other kid who was like highly needy, really reactive, needs a lot of touch and attachment for regulation. Those were not words I had in my vocabulary, and I could not understand. Even with the first two kids, it took me a while. So, but you don't have any benefit of being, I think, more experienced at the time you had kids. Like, yes, you could tune into that. So it was that your decision and how you dealt with sleep was also deeply entwined in
Yeah.
understanding your child too. And that needs to all be part of the conversation, because you're right. Sleep training is highly individual, and
Yeah.
just something that works for one family and child sort of match and couplet does not work for the other. And you have to include both those conversations. That's what I try to do and explain in
I
the
love that.
experience
I
that you
mean,
have to talk about.
yeah, yeah, I love that. How is sleep going in your home? And do you feel like you need any support in that area? Is kind of the added question, because sometimes they're like, nope, I'm good. And then if the family is bed sharing or co-sleeping, by that point, that family has usually made a reduced risk decision, and then I just remind them of the safety risks, which we'll go over, not to like judge them, but to say, hey, love that. Just make sure if you're drinking or anyone's a deep sleeper, or if it's another member of the family who's not used to being with the baby, but we'll get into that. But, already I really appreciate this conversation, because I think what I want people to understand is that myself, we may be anomalies. Like I'm being honest with you. And I think you may know that there is still a lot of pediatricians out there that do take the hard stance. And can we convince everybody? No. But can we maybe give them the resources with this conversation to bring it to their pediatrician and say, you know what? this is what's working for our family. I
Yeah.
listened to this episode by two pediatricians. I would love to just have a conversation with you about it. And at the end of the day, I think you and I both know that if a family feels like a strong value set is not being heard by their pediatrician, it's okay to go find another pediatrician if you have that opportunity, right? I understand not everyone lives in an area that has that, but
Right.
I think what's often done is like, when I was in that very hard stance phase, like not shaming, I wouldn't shame, but I would just say, hey, just a reminder, we need to, independent sleep space. I wouldn't even entertain the bed sharing, right? I wouldn't even talk about it. I'm sure there were families leaving thinking, well, this doctor just didn't even discuss something important to me. And
Right.
now I look at that as, oh, I lost a huge opportunity, like you said, right? I lost an opportunity to help a family reduce risk and understand that, you know what, this is happening in other places too. And so now I want to go into like this risk reduction, which is the meat. So people, I hope they're staying here because this is where we need to like understand how to reduce. Now, there's something called the Safe Sleep 7. Are you familiar with that?
Absolutely. Yeah.
Okay. So first of all, we can before we get into Safe Sleep 7, because I think it's an important thing. Um, what are your thoughts about it in general? What would you like people to know about it when they're approaching it and when they hear non-medical experts speak about Safe Sleep 7? I have my own thoughts.
I mean, so I have to say, like, recalling all seven right now at the top of my head, but I think it has to do like, full
Yeah, I
term
have all of them 7 too because I had yeah, yeah.
that it is a great way to frame an understanding of risk and harm reduction, and that is a valid way for anybody. And as a parent, it's a valid way to look at, okay, if I want to make these choices and I want to do these, this is a great way to understand, hey, checking all seven of these boxes really does make a big difference when it comes to my understanding of risk and risk reduction and harm to my child when with making this choice around sleep.
Yeah. And so I obviously started looking more into it because it's very common in the co-sleeping educator space, right? With the bed sharing space. And not a lot of pediatricians talk about it because of this whole nuance discussion. Well, that goes against the AAP guidelines. And the first conversation I want to say is that if you actually go on the AAP Healthy Children website, they do take their stance that is more blanketed of like, independent sleep space this is what we know. But there is a section on their website that if you do bed share, here are some reduced risk practices. So it's been a newer thing I've seen in the last 7 years. And I want to say like,
You got to go down to find
you have
it.
to
It's
go
not
down,
top,
yes. But
right?
now we're bringing it to the top of this conversation. But I bring that up because I appreciate them in a way that is them not trying to support it. And maybe we can, and later we'll talk about why we feel like the AAP is just not saying what we want to say. Like, just say this, say that we can reduce risk. But I want to say that if anyone's listening, they're like, this is going against evidence-based guidelines, that there's not a lot of good evidence for what we're describing. And I want to reiterate that in that we don't know the evidence surrounding reduced risk bed sharing, but that means that it doesn't mean it's harmful. Like, I want to be clear. Now, the Safe Sleep 7, what I want to also be clear about is that it's not a validated evidence-based guideline. So if you are an evidence-based person,
Yeah.
you might be arguing with us, and we recognize that. But that doesn't mean it's not a good way to reduce harm. So I wrote it all down because I also didn't want to forget them because I have them because it ends up coming out in all the things we talk about. But
Yeah.
here's okay, so everyone, and I'm sure you'll agree with all of this. So non-smoking household, not just a non-smoking parent, but a household that's a non-smoking household because
Yeah.
smoke can linger.
Prenatal too and postnatal, like either.
Yes. Okay. And maybe we can go through these and then we'll maybe explain why that's a risk.
Yeah, because the tobacco smoke has a significant impact on your child's, even prenatal exposure, the development of your respiratory center, and those kids certainly clearly have differences in how their respiratory drive and arousal and all those things. Tobacco directly inhibits that, and it's highly dangerous to that issue. So any alternative sleep choice is going to be impacted risk-wise by tobacco exposure, either before or after pregnancy.
Love it. Agree. The next one we kind of talked about, which was a sober, no alcohol or sedating medications. I don't think we need to explain that, but maybe do it. I would love just for people to understand. Yeah.
Exactly. I mean, if a parent is impaired, their own arousal system is going to be impaired, and they're not going to respond to their baby movement, sound in the same way if you are drinking or have to take opioid medication for pain or things like that. So either of those are going to be impaired, which is dangerous.
Yes. Okay. So that was two. The next one was a breastfeeding parent, which you talked about, like having a breastfeeding parent. But why can that reduce the risk of SIDS? Why that? Why may that be something that someone may do and approach bed sharing?
So we do know that breastfeeding moms are deeply tuned into cues from their kids unconsciously. Kids who are babies who are breastfed are aroused more, in proximity to the mom, which is itself an independent protective mechanism around SIDS and suffocation. And moms who are breastfeeding instinctually kind of create a safe space around their baby. And this has been shown across multiple cultures and places in breastfeeding moms who are sleeping with their kid that they they create this sort of C sort of shape because when you're lying and breastfeeding your baby, you kind of instinctually do that. And then I always get the question, well, what about formula fed kids? And well, it's just not the same. You don't duplicate it the same way. Not that it can't be safe, but we're talking about the seven checklist. Breastfeeding is on it for that reason. They arouse differently breastfed babies, and moms respond differently because of that breastfeeding relationship.
And I'm an IBCLC also. So like I know the breastfeeding mechanisms, the hormones, and having done one child who had formula and one child who had breastfeeding, albeit it was more pumped feeding that we did with my daughter, but still there is a difference, right? It doesn't mean that there won't be a family listening that may bed share with their formula fed baby just because they think that that's something they want to do. And then as long as you're following all the other things, I think that's reasonable. But it so happens that I do feel I don't hear a lot of my formula fed babies bed sharing. Like I hear more from my breastfeeding parents. Like I don't know if that's your experience too. I just don't. It's not something that I'm hearing of. I don't think I can remember the last patient I've had who's formula feeding and also bed sharing.
Or what happens, once again, we also had multiple kids with some were breastfed, a few were not.
Yeah.
In the not, let's just take the formless fed situation. There's the option of the partner getting up and managing
Yes.
the needs and allowing the mom to rest. Like that's an option, and that's exercised frequently. In an exclusively breastfed baby, that's simply just it's if you're making that choice, that's not an option. And yes, and so the breastfeeding mom is getting up every 3 hours, sometimes 2 hours, and the exhaustion kind of gets to be overwhelming after about a few weeks. And so just that choice of bringing the baby next to you to feed and sleep was way more, just feels way more intuitive and natural because you don't have the option of the partner managing it.
Yeah. The next one we talked about as well is healthy full term baby. So the risk of having like a preterm baby and bed sharing.
Yeah. Preterm babies have also different arousal. When babies are premature, their other neurodevelopmental cues are also behind, and they're also smaller and weaker, and they have less reserve, especially respiratory reserve. So there's lots of physiologic reasons why a preemie, and in terms of what do you call a preemie at what level,
Mhm.
I don't know. That's not really outlined. Is 37 weeks too premature? Is 36 weeks or 35 weeks? The cutoff is not clear.
Yeah.
We have to be transparent about that. But I generally use myself. If you're under 38 weeks, I'm gonna at least advise you on that. There's a slightly elevated risk.
I love this already because you are exactly saying what we do and do not know. And that was the point of this conversation. Like you said, there because the AAP does not have a hard line, right? Because we don't know the data of what is that week, and also the babies can be different, right? We know that even within preterm babies, there's so much variation within what was the reason for their preterm delivery. So I love also the healthy. When we talk about healthiness, like what's going on with the baby. This is one of those conversations where I wish pediatricians would be able to be more open about this entire conversation that we're having to guide a family and say, hey, look, I think that I understand that you want to do bed sharing. I think at this point, I'm not shaming you, but let's just make sure that we're doing the independent because of X, Y, and Z. We don't have all the data, and this is why I recommend it. So it doesn't feel like they're not being listened to. They feel like, okay, the doctor understands that this is something I wanted to do, but because of my kid's age, we're not going to do it. And it's just to protect the baby as much as possible. So I love that one. We have three more to go. We did four. So babies sleeping on their back, and then we'll talk about where they're sleeping, but on their back and not on their belly in the shared sleep space.
Right, exactly. So, we did this, and all the parents who I talked to, you pull the baby in, you feed them, but then you just sort of move them on their back in that safe, protected space, near the mom, as opposed to, resting on their side or on their front.
Yes.
There is there's definitely a risk reduction there, choosing to do it on their back.
And I think I'm gonna jump to the number 7. I mean, you can do these in any order, but they're not like a,
Yeah, there's
Jeopardy. But this kinda goes into, like, when the baby starts to roll on their side, the baby starts to roll over in a bed sharing space. That number 7 was a safe sleep surface, which is a firm mattress, no pillows or loose bedding near the baby,
right.
and that would also help when they start rolling to their side as well.
Correct. And I think that when that also plays very much into the question around, well, other countries do it.
Yes.
When we see other cultures, and listen, I'm not going to pretend that I am a international traveler, but when I've looked into it and seen what they mean when other cultures are doing it, they are doing it on firm, flat surfaces. They don't have 17 pillows like we tend to have in America, and a duvet and a comforter. They
Yeah.
don't, right? They don't have that. None of that stuff is there. So changing your sleep space to reflect what that looks like, in Japan, in India, makes a difference.
Yeah. I A lot of my information about this came from Dr. Imran Patel. I have to call him out. He's a pediatrician in India,
Yeah,
huge following because obviously India has billions of people.
right,
But yes, he said the same thing, and I've seen it when I've traveled. I've seen the floor beds. A lot of the families have beds on the floor, and it's a firm mattress, like you said. The baby, which was number 6 that we jumped over, has
mhm.
minimal clothing on. So there's no overheating. It's not like they're in like 7
Zip
suits and like
there. Yeah,
8,000 swaddles. And interestingly, we know that they don't need a lot of the swaddles because they're closer to the parent, right? Like meaning the reason why swaddling exists is that it sort of mimics what a baby may want from bed sharing in an independent sleep space is what I believe is why we do the
correct,
swaddling. Yes.
correct. I mean, listen, the swaddling is to provide that binding comfort, to recreate, closeness with the parent and or the womb. I mean, I think Dr. Karp has made quite a fortune on his snoo product,
Yeah. Yeah.
on that thing. So therefore, I think that that is very astute. That it's just recreating what you're giving when you are providing the physical closeness, for sure.
And then in terms of newborns, because I know there's like we talk about how the SIDS rate is,
Mhm.
higher in the first 3 to 6 months.
Yeah.
Is your approach the same for newborns? Like what we're talking about here, like all of the Sleep 7, or would you take a little bit more nuance within the Safe Sleep
I
7
mean,
for
once again,
newborns?
a full term, busy, active newborn who's waking up on their own, and is that's a very different discussion. I think what it's baby to baby in my
Yeah.
opinion, when it comes to the newborn.
I love this. This is so great, and thank you again for like adding in all the. I wanted us to have this discussion so we could add in all the whys and the explanation and where the nuance is still existing, and so that families can make that best decision for their family with that reduced risk in mind. And
Absolutely.
so, just to reiterate, the situations we do not love. We already said smoking, alcohol, drug use, sedating medications, prematurity. Speaking to the clinician, and then we talked about this in earlier, which is the couch, recliner, or
Oh
soft
yeah,
surface.
those
So
are the highest
if you wanna
maintenance.
talk about that is, like, if I wish they would break it down. I don't know, I have to look into it, and if I do find the data on, like, how much of it is in a couch, recliner, soft surface, I'm gonna include it at the beginning of this conversation as an intro, but to me, that's where I'm seeing the most of it. Like, that is
In my
where I see it.
practice, where it's happened, tragically, has always been in one of those specific cases.
So let's talk about the couch and recliner. I think soft surface, we already understand that it's because obviously it's a suffocation hazard if they're putting their face into a soft blanket or a soft pillow, but the couch or recliner.
So the couch recliner is that those spaces on the side, and a baby, especially in the newborn phase, they can roll and get trapped. And
Mhm.
if you're exhausted, and it can happen sort of subtly, and your baby ends up wedged into the in between you and the bar and the arm of the recliner, or the arm of the couch, or where the space between the cushion and the side of either recliner or couch, and your baby can get stuck there, and it does not take long and they can't, they're silent. Unfortunately, they're not going to be able to. people think, oh, I'll hear them cry. No, you won't. Especially if they're small enough and they're newborn enough, they are just going to suffocate there.
And also in many of those situations, the parent is also sleeping. And
It's
like, so
totally
so like
exhausted. Like that's why
right.
they're there and they're totally asleep. And that
And then if you're in a deep sleep and you don't hear that, then of course there's tragedy. And it can be so scary to talk about these conversations, but I hope people feel educated and empowered to say, you know what, I'm gonna do my best. I'm gonna do all the things to reduce that risk. And I love this because this is how we do it, right? This is how we educate our families to say, yeah, this is what I wanted to do. It feels the most natural to me to bed share. And now I have some tools that understand how to reduce that risk. And then
absolutely.
of course we talk about the couch and like the recliner. Yeah, the couch ones are the ones that are hardest, and we talked about that earlier. That well-meaning families who maybe don't want to do bed sharing. One of the partners takes the baby out of the room so the other partner can sleep.
And rest, right? And they're
Yeah, just
totally
giving a
exhausted.
scenario, and then they fall asleep on the couch, and the baby is like neck
Mhm.
flopped or face into the parent's chest the entire night, or into the pillow on the
It's a,
couch. And
or they slide into
yeah,
space without knowing it. Those were unfortunately the ones in my office that we've had most, thankfully not for a while, but that was the last one. Was exhausted
I
while they're on a
yeah.
recline. Yeah, yeah.
Yeah, and I think what we said earlier, that data that we look at obviously is looking at the riskiest forms of bed sharing, and so it's really important to know that, right? The AAP's, I think the most recent safe sleep guidelines came out in 2022, I
20,
believe.
the back
Yeah,
to
and
sleep.
it's like the most recent updated was the room sharing for 6 months, which was a new recommendation. Not bed sharing.
I mean, the room sharing was 12 months, and honestly, that was see, I had so many discussions with parents who are like, we need went to that discussion about what we need. We really need to
The
sleep train.
baby in this.
We're
Yeah.
told they have to stay in a room till 12 months. Like that was patently ridiculous, in my opinion.
I so funny because that was my next question because although we're talking about bed sharing, I just want to have this conversation is also just about the recs in general, and that is the room sharing rec. I moved my son out at 2 months, but moved my son out at 2 months of age, but I shared the room with him and not my husband because it was COVID time,
Yeah,
and he needed to get sleep as an ER doctor, and I was still on mat leave. And then at 4 months, I went back into the room with my husband, but then I still went back into my son's room because of we didn't know what COVID was, right? I didn't want to share a room with him and get COVID and bring it back to my son.
he
With
was
my daughter, we were like, hey, like when are we ready to go out? But the room setup we didn't have a room for her and a crib for her to go into. So that's why she shared a room with us. But
he was stuck.
exactly what you mentioned, like the recommendations came out for room sharing. Again, we're talking about room sharing for 6 months. And that was including, not bed sharing. That was the AP rec. And so many of my families, like you said, were like, I can't do this. I'm going to wake up more. And to your point, exactly what you said, as long as it's a non-smoking household, I was okay with it. As long as they weren't premature, I was okay with them going into their other space. Was there any reasons that you would not be okay with someone separating their baby out into a separate room?
No, I mean, once again,
Earlier, or
under very
yeah,
specific conditions, but a healthy kid.
yeah,
And we also know that all babies are going to arouse more just because of the proximity to mom. And if you are trying to do that calculus about I'm exhausted. I have to go back to work. I need to at least explore a sleep training option. The first thing is to move your baby to a separate sleep space because a lot of babies will just sleep longer because they're not in that proximity to mom, which does generally arouse them more. Just
yeah. On that topic of arousal, because there's been a lot of discussion in the people who are against sleep training or independent sleep space, like people who are like it's not safe. I want to be clear. So when we talk about arousal, of course, yes, being close proximity is going to arouse them, but that's different than like the baby is still arousing in an independent sleep space, meaning they're still breathing. Because
they're
what I
still
think is happening is people
yeah,
are equating that they arouse and you need that arousal to survive. But
yeah.
babies who are independent sleep spaces are still breathing and arousing, just not as
Absolutely.
frequently
There's definitely
as bed sharing. Yeah.
there's definitely a factor of maternal proximity that just stimulates more of it.
Yes,
And
yes.
so you get a little bit more space, slightly longer sleep windows in a lot of kids. And once again, every kid is different and no two kids are going to respond exactly the same, but that can be just a simple measure in a kid who's you've reached that point um, of development. And for most kids, that's after 6 months, where they have at least some of the developmental resources to self-soothe and to self-regulate more, where separation makes sense if you want to go that route, because you need to at least initiate the process because of your going back to work, all the factors, the
Yeah.
nuance factors in discussion that are all there that are different for every family. Your needs were different, and so, but that is a good first step that I often start with.
Oh, this is such a great conversation. I knew it would be. I am just so grateful that we can have all of this out here as a resource for our communities, for the families that are looking for it, because there is a gap in the education. And for us to be able to just dive deep into it and just get into it was just so beneficial. I loved it. Again, I love learning from you. A lot of the stuff I already knew and have been doing already, but just to validate
Yeah.
from a fellow pediatrician to tell me, yeah, okay, as a newbie doctor, meaning 11 years compared to your experience, to be like, okay, this is what I was saying to my families. I feel justified in understanding that, Safe Sleep 7, although it may not be an evidence-based resource, it still is really accurate in saying,
Oh,
okay, these are the things that we know that can reduce the risk. In your opinion, what is your biggest goal with families when it comes to sleep guidance and support? And that just includes whether they sleep train, whatever method they choose, bed sharing. What is something that you just wish every family could get from their pediatrician as well?
the first thing, and is that as someone who's fully involved in a practice that I own that's insurance based, is time. The
Yeah.
problem is, and I think one of the reasons that pediatricians tend to default to just the dogmatic AAP view is simply we lack the time to have the meaningful, nuanced conversations that these topics deserve. Sleep being
Yeah.
one of them, but eating and ADD, all of them.
Yeah.
We are not afforded the time by the system because of how it all works, and the economics of this are complicated, and this is not the time to talk about it. But just know that insurance creates a system that makes it mostly impossible to give a topic like this the time that it deserves to flesh out the nuance individually, which every family deserves and needs. It's just not possible. It's way easier to go, yeah, back to sleep, AAP says, gotta go, three
Yeah.
people waiting. That's the problem. And I wish that what families got was the time, because most pediatricians know this. It's really not something that most pediatricians are ignorant of. They all understand it. It's the ability to dive into it in the way that gives parents what they need, is they lack the time
And
because
that
of
is
the system
and
that
that is why you started your platform. That is why I started mine, by the way. I don't think you know my origin story, but I was working at a big box corporate medicine practice,
oh yeah,
seeing
yeah,
patients every 10 minutes. And I
yes,
just felt so burnt out because I didn't have the time to explain
yes,
all this middle ground, like all this sort of, hey. And so then what it ended up being is an outlet for me. I didn't imagine it would become what it is now, an outlet to be like, you know what? I want you, if you can, please. Here's the TLDR or TLD. Didn't listen. Please go read this article, or please go watch this Instagram reel or IGTV that I made back in the day when that was what happened. Because
IGTV.
I do feel like people need this, and we for the last 48, 50 minutes were able to give people that, and I'm just so grateful for you for your time.
Yeah.
What would be your final uplifting message for everyone tuning in today?
I think that being empowered to know yourself and know your children and know how those intersect with your needs is valid, and it's okay. And you need to be able to talk about it, and all of it has a place.
Yeah,
And and there is so much nuance and space to do things right. And what's right at your house doesn't have to be right at someone else's house,
yeah.
and that's okay too. And this whole, I think parents feel overjudged, feel over scrutinized because of the world we live in social media. So that's my message that I try to leave everybody with on all these topics, not just sleep.
My little snap fingers as an
Yeah.
applause. I really appreciate it. And the final question is out of left field, but what's making you happy right now in your life?
Being able to actually spend the time and reach more people than I'm afforded to in the traditional system, and to have a platform that's big enough is bringing me an enormous amount of joy and fulfillment and filling my bucket, because I can actually deploy all of this knowledge and things that I've accumulated in a way that in a time frame that isn't limited by things that I can't and families can't control. And that's what I really love. That's what I love about the platform that we made, the Raising Well platform, and the
Yes.
Instagram channel. Is that's the reason why it's there, is because that's the need I'm trying to fill. It's the need I feel is lacking every day in a traditional office system.
And I'm thankful for you doing it. Tell people where they can stay connected, including the Raising Well platform, and so that they can get more information. A little info about that as well.
Yeah, sure. So the Instagram channel, and we really try to answer questions and as much as we can at Dr. Michael Milobsky. And that's where you can find the information about Raising Well, which is our parent platform, which is designed to give parents the time and space to explore deep and nuanced topics in a way that they don't often have the time to. So there's a library of content on all these topics, 2 live calls a week, and a live open question answer stream that we manage that allows us to touch more, do more, be more present, be more available for these topics from someone who has that to offer at 30 years of being a pediatrician and a parent. And so that's those where both of them exist.
I will be adding this to our show notes, and what an awesome conversation. I know we've connected even before this. I love chatting with fellow pediatricians who are doing this hard work, not only seeing patients, but also, online. I know it requires us to show up in unique ways.
Yeah.
And I'm so happy that I get to do this job with you. Like,
Yeah.
thank you for being a colleague in all the work that you do online and in real life. And I know this is not going to be the last time we're on the show together. And I think maybe we need to start our own show together, me and Dr. Michael.
I think a separate and maybe tour. I think a live
I
tour.
know. Oh, yes. Well, listen, where are you based again?
I'm in Denver, Colorado.
Denver. I now know that when I'm writing a book, so I now know that when I coming to Denver, you are going to be my co-host on that conversation. We are going to talk about this. You're going to interview me, and we're going to chat all about it. I haven't announced to my community what the book is and when it's coming out, but just know you are my person now, because
I'm ready to go.
we have to have more conversations, my friend.
And it's good to come to Colorado because you could experience a snowstorm on May 6th.
Oh, wow. Okay.
It was a
I
snow
don't,
day for most of the school systems, and tomorrow you will not be able to know it was there because it'll be 75 degrees. That's
wow. Okay,
Colorado.
yeah, maybe I'll come when it's not volatile, but
Yeah,
how can we
it's
know?
not that,
Oh
yeah.
my gosh. Well, thank you so much for everyone tuning in. I'm sure you learned something, and we hope that we gave you information that you may not have gotten from anywhere else. And it was important for me to get another pediatrician on the show. I know there's a lot of resources out there, but as Dr. Michael has beautifully stated multiple times, there's so much gray area that I felt like it was important to have a fellow doctor to give that with you. And so if you love this conversation, hit that thumbs up sign, comment, what did you learn from it? Who are you sharing this with? And please make sure you're subscribed to the channel. And I cannot wait to connect with Dr. Michael in the future. Thank you.
Thank you.